Hi, everybody. Thanks for the opportunity to speak to you about the changing landscape for stroke intervention. I believe that this may be the closing presentation of this conference, and I hope you've had a wonderful conference and look forward to speaking to you further in the live question and answer session. So these are my financial disclosures. And what I hope to do is talk to you about the landscape in terms of what we know and what's on the horizon in terms of IV thrombolysis as well as endovascular therapy to treat acute ischemic stroke. So it's old news that IV thrombolysis is indicated for patients within 4.5 hours from last known well. And we know the faster we treat, the better. For every 8 patients we treat within 3 hours, we make 1 person better in terms of no disability. For every 14 patients we treat at 3 to 4.5 hours, we do the same. And those numbers are a lot lower when we consider who we make better by just 1 level of the modified Rankin scale. So that number needed to treat is about 3. So more recently now, in the last couple of years, we've learned that we can push thrombolysis beyond that 4.5-hour time window. There was the Wake Up trial that showed us that if a patient presents within 24 hours of last known well and with unwitnessed onset of stroke, and the patient is conceivably within 4.5 hours, and we do an MRI where we see DWI positivity without marked flare hyperintensity, something subtle is okay, but nothing really obvious, then we will show similar treatment effects as we did with TPA within 4.5 hours. The treatment effect here in the Wake Up trial, which was run in Europe, a European Union Commission trial, showed an 11.5% absolute risk difference in terms of improving patients for a modified Rankin 0 to 1, in other words, having no disability. In addition, the Extend trial came out shortly thereafter, suggesting that if we look at patients who are 4.5 to 9 hours from last known well, whether it's Wake Up or witnessed or unwitnessed, that we can, again, potentially improve outcomes. The number needed to treat there was 17. And it was the selection paradigm was using CT perfusion. And in that case, the imaging parameters were a bit broader than we'd use for endovascular therapy that I'll be telling you about later. But certainly raised this possibility that there are some patients where we can push the limits to 9 hours from last known well. One of the big topics at the cutting edge right now is whether we can switch to tenecteplase instead of alteplase. Certainly the evidence is growing. There have been several randomized trials, each with different patient populations. And perhaps the strongest evidence at this point comes from the TACE and the Extend IA-TNK trials, both looking specifically at patients with large vessel occlusions and suggesting that TNK may be appropriate. In fact, the European stroke guidelines suggest that for patients with ischemic stroke within 4.5 hours and a large vessel occlusion on their way to mechanical thrombectomy, IV thrombolysis IV thrombolysis with tenecteplase is reasonable and suggested over IV thrombolysis with alteplase. The quality of evidence is low and the strength of the recommendation is weak, primarily because these were small studies. There is less clear evidence for all comers within 4.5 hours, for specifically patients not eligible for thrombectomy, and the European stroke guidelines actually recommend against switching to tenecteplase just yet, as the evidence at this point is weak and low for this comparison. I will say that, in some countries, there have been trials of switching to tenecteplase. I know there's a very nice paper out of New Zealand where they showed some of the real world experience of switching to tenecteplase. They're now back to using alteplase until we have more data. There are some cities in the United States that have switched to tenecteplase. I think that it's something where we should have more definitive evidence soon to make it clear that we should switch to tenecteplase. But I think it's a tough decision to make for all patients, and it's certainly much less safe to be using different drugs in different scenarios, considering that they have very different dosing regimens. So I would say broadly, the consensus right now is to stick to alteplase just a little longer. Certainly that's what we're doing at our center. And we are anxiously awaiting the ACT trial. It's one of many trials that's testing tenecteplase head-to-head with alteplase within 4.5 hours. It's run out of University of Calgary, and I recently learned that they enrolled their 1,600th patient just a couple weeks ago. So we really should know, have some data to potentially make that full switch to tenecteplase if this trial does confirm its non-inferiority and perhaps its superiority. These results should be out in the spring. We also look forward to having more novel agents beyond tissue plasminogen activators as we move forward. There was an international stroke conference talk where we reviewed some of them. Just a few examples. One is von Willebrand factor antagonism, with the idea that, you know, in addition to fibrinolysis, we should attack the pathways by which platelets clump together and get activated. One of the agents in aptamer that's under development is DTR-031, and it's actually beginning trials soon in human stroke patients. Another study that's further along is the MOST trial run in the United States, where we are actually looking at adding a drug to thrombolysis. We're looking at both adding GP2B3 inhibitor called eptifibatide, or a direct thrombin inhibitor called argatroban. We're comparing those to placebo, and the winner will then be compared against placebo to end with a definitive result, hopefully showing us that we can more completely and effectively open up vessels and improve outcomes by giving a combination of IV thrombolysis with one of these two agents. There are several other agents out there. There's one that's been developed in Taiwan called LT3001. It seems to be a combination lytic and cytoprotectant. There's a drug that I'm working to develop within NIH StrokeNet, which is works on alpha-2 antiplasmin inhibition. It's called TS23. And the idea here is that if we take the brakes off of antiplasmin by inhibiting it, we can take the brakes off of endogenous fibrinolysis and take advantage of what our bodies are able to do to break up those blood clots by releasing those brakes. And again, there are several others, but there are many reasons to be hopeful that we will have some new agents that are stronger, more effective, and perhaps with less side effects than IV alteplase or IV tenecteplase. So what about our patient that shows up early with either a hyperdensity on CAT scan, or if we've done a CTA, shows a large vessel occlusion here with an M1 cutoff? Well, at this point, it's well established. This is old news that within 6 hours, if they present within 6 hours of last known well, endovascular therapy is strongly indicated. We know that this is one of the bigger treatment effects in medicine in terms of bringing the patient back to functional independence, as well as an absence of disability. So the main criteria to keep in mind are saying no extensive early ischemic changes based on an aspect score. For those who aren't familiar with an aspect score, we basically break down the CAT scan into regions at this level where you can see the thalamus and basal ganglia, and you get 1 point each for each of these regions of the brain. And then we go a few cuts higher and we give additional points here. So the total number of points you get is 10 points. 10 points is a perfect, beautiful scan with no early ischemic changes. And the more changes you see, the more you subtract off. So at this point, standard of care is to offer endovascular therapy for patients with an aspect score of 6 or more. In addition, patients with NIH stroke skill score 6 or more are routinely offered endovascular therapy. And the goal is to move to the endovascular suite as quickly as possible, because while this is just like thrombolysis is a very time-sensitive treatment, so the sooner we can get that vessel open, the more likely the patient will do well. So there are several trials on the horizon looking to expand eligibility. One of the thoughts is that maybe we can actually make a difference with treatment of patients with aspects of scores of 3 to 5, or even 2 to 5. The tension trial is going on in Europe, testing patients with an aspect score of 3 to 5, randomizing them to thrombectomy versus standard care. The Tesla trial is in the United States, randomizing patients with a non-contrast CT aspect score of 2 to 5. Again, looking to see if endovascular therapy may be superior to standard of care, and both are quite promising hypotheses, and we look forward to these results. We're also looking to consider whether we should treat patients with mild strokes, those that either don't appear clearly disabling or are certainly low on the NIH stroke skill score. For those who don't know this, among all the randomized trials of endovascular therapy versus placebo, there are about 1,800 patients enrolled in those. Only 14 patients had an NIH stroke skill score of 0 to 5. And so we're really in uncharted territory there. I think the main reason to treat these patients is sometimes when their NIH stroke skill score is 0 to 5, it is indeed a disabling event, and maybe getting that clot out would make a difference. But perhaps even more importantly, about 1/3 of these patients decline and develop a moderate or severe stroke over the next 24 hours. And if we could catch them before the stroke even started, we may see the best outcomes. So the ENDO-LOW trial, which I helped to lead internationally, is occurring right in the United States. It's underway, as well as in Canada and in Germany. Another trial that's going on largely in France and at a few US centers is in Extremis. And that too is randomizing patients with NIH stroke skill scores 0 to 5. So once we get beyond 6 hours, we have also learned that selected patients benefit from endovascular therapy, and that data are particularly robust. Both 2 different trials, the DAWN trial and the DIFFUSE-3 trial, suggested that patients who have favorable CT perfusion data do benefit from endovascular therapy compared to medical management. I'll spend a moment just showing you that there are multiple different softwares that we can use to process CTP data, and that to date has been the most reliable way to select patients who would benefit from endovascular therapy. And so you can see examples of the various softwares here. And what you get is a picture like this, where you can see an area of irreversible ischemia, like right here, associated with a cerebral blood flow of less than 30%, 26 cc's here. An area where there is delayed blood flow, where the Tmax greater than 6 seconds to show blood flow in these areas of hypoperfusion, in other words, and this area is 181 cc's. We then look at this ratio. This mismatch ratio here is 7. And we use this threshold of a mismatch ratio greater than or equal to 1.8 to take patients to thrombectomy. So to give you a sense, again, we're talking about pretty substantial treatment effects, even when we take thrombectomy out to 24 hours in selected patients. For every 2 to 4 patients we treat, we bring 1 patient back to functional independence. You can see here the results from the DAWN trial, where 48% had functional independence with thrombectomy compared to 13% in controls, and very similar results with the DIFFUSE-3 trial. The DIFFUSE-3 trial used that target mismatch criteria that I just showed you, with a mismatch ratio of greater than or equal to 1.8. And this is probably the most common definition used, as it largely encompasses patients that would have been eligible for endovascular therapy based on the DAWN trial. The CTP processing software is expensive and certainly not an option all over the world. And even in many developed countries, high-income countries, they've chosen not to invest in the software. And what remains to be seen is whether we can select patients for extended time window reperfusion therapies using CAT scan alone. The early data suggests that this may be very feasible. This is a really beautiful study led by Tan Nguyen and colleagues, where they created a multinational cohort study of consecutive patients retrospectively collected who had proximal anterior circulation occlusion strokes presenting within 6 to 24 hours. And collecting their data and looking at their outcomes, they represented centers and physicians that used a variety of approaches for treating patients in this extended time window with thrombectomy. They had 534 patients treated with CT, using CT as the decision maker, 752 using CTP, and 318 using MRI. And what you can generally see here is that patients generally look pretty comparable in terms of their outcomes with all three of these modalities. Of course, there are all the limitations of retrospective study, including confounding by indication. There may have been reasons that some of these patients were taking the thrombectomy beyond what we're able to capture based on the chart data alone. And so while this isn't definitive data, it certainly does give us hope that we can select patients more easily across the world, even without CT perfusion data and using only a CAT scan. There are two ongoing randomized trials that will definitively answer this question about using the CAT scan without the CTP. And they are Mr. Clean Late, which is occurring in the Netherlands, and Resilient Extended, which is occurring in Brazil. So both of these will be very helpful studies in framing our thinking moving forward. Another area that has been cutting edge and of interest is whether we should be treating patients with thrombolysis if we are already going to go to endovascular therapy, particularly if they present at an endovascular capable hospital. Many pros and cons to consider of IV thrombolysis in this setting. And there have been several randomized trials published now, DIRECT-MT in China, DVT also in China, SKIP in Japan, Mr. Clean No IV in Europe, SWIFT Direct, which was in Europe and North America, and then Direct Safe, which was in Oceania and Asia. And they all use different non-inferiority margins. In other words, margins by which TPA should be, bypassing TPA doesn't lead to margins by which we can accept a worse outcome by bypassing TPA. They were relatively generous margins, and they all had different conclusions about non-inferiority. DIRECT-MT and DIRECT-EVT both suggested that bypassing thrombolysis was non-inferior to bridging therapy, again, with generous non-inferiority margins. So there's a really nice webinar that I encourage you to Google if you'd like to review more about these data through the European Stroke Organization. They did a guidelines webinar just a couple weeks ago and summarized their meta-analysis, which includes all of the available trials right now. The guideline has recently been published that goes along with that webinar, which I had the opportunity to co-author. And we went through a very rigorous process to consider what non-inferiority margin would be appropriate for bypassing thrombolysis. There are several things to consider, including the fact that a lot of our trials are published for treatment effects of 5% and even less when drugs are particularly safe. The consensus in the group of authors was to use a non-inferiority margin of 1.3%, which was something that had been studied in the setting of neuroprotective agents and published previously based on a survey. So the idea there is that you choose your non-inferiority margin. That's your margin by which you are willing to accept a worse outcome by using a particular treatment. And then you look at the 95% confidence intervals of your randomized trial and you see if that non-inferiority margin is outside of those 95% confidence intervals. So in other words, if you had a result like this, where the 95% confidence interval ended before hitting that minus 1.3%, then we would say that non-inferiority had been demonstrated. However, if it crossed that minus 1.3% line, that means that our treatment that we were testing for non-inferiority may still provide a benefit of 1.3% or perhaps a little more as this line extends, and therefore non-inferiority has not been demonstrated. And so we did a meta-analysis based on aggregate data, random effects model, and basically showed that our non-inferiority margin, which is represented by this dotted red line, was included in the 95% confidence interval when you pulled all these studies together. In fact, the lower limit of the 95% confidence interval was minus 6.76. In other words, we had not eliminated the possibility that TPA was providing up to a 6.76% treatment benefit for modified Rankin 0 to 2 outcomes. So with that in mind, the European Stroke Guidelines declared that we should not bypass IV thrombolysis in the average patient, that the quality of evidence for not bypassing thrombolysis was moderate and the strength of the recommendation was strong. I think there's some arguments to be made for targeted decisions to bypass thrombolysis in certain cases, certainly if the patient has more risks with systemic thrombolysis. Perhaps if they have a particularly heavy clot burden that looks resistant to thrombolysis, it might be considered. And we certainly need more data to consider personalized medical decisions. So the current clinical landscape that I've sort of laid out for you is that thrombolysis within 4.5 hours of last known well is indicated by intravenous means, endovascular therapy within 6 hours, and both together is safe and efficacious in the same patients. At 4.5 hours, within 4.5 hours, beyond 4.5 hours, I should say, thrombolysis is by IV intravenous thrombolysis is recommended in selected patients, and beyond 6 hours, thrombectomy is recommended in selected patients based on advanced imaging criteria. However, it's notable that there have been no completed trials in the extended time window where patients received both IV thrombolysis and thrombectomy. And there are a couple trials going on worldwide where that are testing giving TNK before thrombectomy versus giving thrombectomy alone. And so we look forward to those studies results. I think we would all agree, though, we have a lot more work to do, even though it's been an exciting time with lots of new developments. When we treat our patients with our best reperfusion therapies, we still leave about half of patients either functionally dependent or dead, and only a quarter of patients disability free. So we still certainly have a lot of work to do. One of the trials that created a lot of excitement that was just presented at the International Stroke Conference and published in JAMA was the CHOICE randomized trial. This was led by Angel Chamorro and colleagues in Catalonia. And the trial was small. It had 121 patients. They were randomized to intra-arterial thrombolysis after having a successful result with thrombectomy. In other words, if they had a TICI-2B3 result, relatively good result, at least half of the distal vasculature had been opened up with thrombectomy. They randomized them and gave IA-TPA distally to that microcirculation or that distal circulation. And they showed an 18.6% treatment effect that was statistically significant. It was a relatively small study, and at this point, I think the findings are certainly preliminary and require replication. The confidence interval was very large for that treatment effect, but it's created a lot of excitement because it's something easy that potentially we could start doing to improve outcomes further. And I would say as a field, we're very excited about subsequent testing of intraarterial thrombolysis after doing thrombectomy, which is interesting because it takes us a full circle. Before we had the thrombectomy devices, intraarterial alteplase was our endovascular therapy, but now we're using it as sort of cleanup after doing our much more effective thrombectomy procedures. I'll also mention that the other exciting area at this point is the reawakening of neuroprotective, or what we like to say more often now, cytoprotective agents that basically buy us time, whether they reduce injury after ischemia or even protect the brain to survive ischemia for longer. These drugs seem to make more sense than ever now that we're definitively opening severe occlusions that cause severe strokes. So one of the agents that we are getting ready to test in a large scale manner in the United States is actually a mutated form of activated protein C called 3K3A APC. It's made by ZZ Biotech, and it has cytoprotective effects with much less anticoagulant activity. And early trials suggest it might even actually protect against the hemorrhage that we see with thrombolysis. So this trial is led by Patrick Leiden from UCSD, and will be a randomized trial comparing 3K3A APC to placebo in patients treated with thrombolysis, thrombectomy, or both. We hope to be enrolling in about a year from now, and we're just starting up. So in conclusion, I hope what I've outlined for you is that IV thrombolysis within 4.5 hours and selected patients up to 24 hours is indicated at this time. Tenecteplase may soon replace alteplase, and there are also very many other exciting developments on the way, including combining drugs with IV thrombolysis, or maybe other clot dissolving agents that move away from tissue plasminogen activation altogether. Endovascular therapy within 6 hours and in selected patients up to 24 hours is also efficacious. One of the biggest major treatments that we have in medicine in terms of treatment effects. The future may not require CTP-based selection for our patients out to 24 hours, so we'll look forward to results on that. And at this point in the average patient, we don't recommend skipping IV TPA when it's indicated in patients who are eventually going to endovascular therapy. We should be giving both as quickly as possible. Certainly, there's much more work for all of us to do to develop these therapies and provide them more widely to our patients. In terms of development, some of the most promising areas are those that involve treating the microcirculation past what we can see with the naked eye in terms of occlusions on the angiogram, and cytoprotection to try to give us more time to save the brain with reperfusion therapies, as well as help the brain with strategies to limit the injury from ischemia. Thank you so much for your attention, and I look forward to speaking to you all in person.